Yeah,
ठीक है,
fine.
1 second.
मैं भी चालू करता हूँ.
कर दो. Yeah.
Yes, sir, we are live.
Good afternoon, everyone. We welcome you all to Rheumat TV Ortho TV combination. And to introduce today's topic and speaker, I hand over to our moderator, Dr. Salim Patel.
Yeah. Thank you, Neeraj. Thanks a lot. A very good afternoon to all our delegates. Welcome to this Rheuma DG Conclave. Today, we have this excellent webinar on the platform of Ortho TV as well as a combination with Rheuma TV. And for today's topic, I would like to first introduce our speaker, Senior Respectable Dr. Lieutenant General Dr. Ved Chaturvedi, sir. He's a professor in rheumatology and immunology at the Sir Gangaram Hospital, New Delhi. Ex-president of the Indian Rheumatology Association. He's an ex-president of the Delhi Rheumatology Association and the ex-HOD of Rheumatology Research and Referral Hospital, New Delhi, with the ex-honorary physician president of India. Sir has been a pioneer in the use of biologics and musculoskeletal ultrasound since the year 2000 and 2003 respectively. He's also been the editor of the Manual of Rheumatology, and most importantly, he's a winner of the President Awardee received for the PVSM Highest Peacetime Award for the Army. Today, sir is with us to discuss about a very interesting topic, the era of a novel DMARD, which is Iguratimod. With this, I hand over the session to our respectable Dr. Ved Chaturvedi, sir. Over to you, sir.
Thanks, Dr. Salim. Thanks for kind introduction. Now let me handle this technical part, like sharing screen and all, which we have learned. So let me do whether I can do it correctly.
Absolutely.
So probably, yeah.
Icon, sir.
Because probably, yes, I think I can see some.
Absolutely, sir.
Yes.
Perfect. It's visible, sir. Over to you, sir.
So, ladies and gentlemen, good morning. Jai Hind. I was a soldier in uniform and I was working in this hospital, which is called Referral and Research Hospital of Indian Army. Probably we are a large country. We don't realize like in US, you have a hospital, which is Walter Reed Hospital. This hospital is a hospital like Walter Reed, very heavily funded. That's why we could use biologics way back in 2000, about 20 years back. And this was the Department of Rheumatology. And this was a Department of Joint Replacement. I'm talking about 20 years back. So both we had pioneer in very modern lab, very modern Department of Rheumatology we could establish in this army hospital. And everybody has to retire one day. So I also became out of uniform and joined equally prestigious hospital, Gangaram Hospital. So I'm here in Gangaram Hospital as a rheumatologist. And this is what Salim was talking about, manual rheumatology. If this is what we edited. This is a official publication of Indian Rheumatology Association. So I advise if somebody has to really see an Indian book on rheumatology, he should go. My topic today is to speak on another new drug for rheumatoid arthritis. Rheumatoid arthritis is a prototype of disease. There are many diseases where rheumatologists deal. Rheumatoid arthritis is very common. So let's learn together about this new molecule, Iguratimod. And in 1991, when I joined the DM program for rheumatology and immunology, I can tell you there are a lot of confusion even today. Even people know very well about cardiology, gastroenterology, and other specialty. But for rheumatology, there are issues probably people feel about that, what they do, what is their qualification. But since last 10 years now, we have almost 10 places where a DM degree is provided. So people who wants to, especially doctors and their children, they must know there are very well established DM program in rheumatology. And you'll be surprised, because I was chairman of selection committee for last 6-7 years. The toppers are going for rheumatology and immunology. So I was also surprised. We were not toppers, but today it is topping the list of the specialty as a physician. Our prototype disease is rheumatoid arthritis. Other diseases also there, which we call it either the spondyloarthropathy or connective tissue disorders like lupus. Like neurology, we must remember, like our colleagues understand about osteoarthritis, where the level of lesion is cartilage. So it's a cartilage disease. Unlike this, the level of lesion in rheumatoid arthritis is synovium. So it's a synovial disease, while the level of lesion in spondyloarthropathy is a tendon in ligament and ligament insertion. So they are different diseases. They are treated differently. So we must know that that is how the science is progressing. These two prototype diseases are different: rheumatoid arthritis and spondyloarthropathy. As I said, it's a synovial disease, it's a ligament disease, it's a rheumatoid factor positive, it's a HLA-B27 positive. Basically, it's a disease of spinal joints, and rheumatoid arthritis, basically more hand joints involvement. So if hand joints are involved, then you are very comfortable in making diagnosis. Basically, other joints are also involved. Look, that is for research purposes. For a clinical day to day, for a general practice, you must remember, if hands are involved, then you can diagnose it much easier. Earlier we used to read about all these deformities, that deformity, which I don't want to name those deformities, but now we want to diagnose it at very early stage, because that is how all diseases are. If you diagnose myocardial infarction early, you can treat it well. But if you diagnose at a very late stage like this, then probably becomes difficult for any other disease. So first thing is to let's learn about diagnosing it early. And then if you diagnose correctly, you should not over-diagnose also. We know there are many other joints are also involved. It's not only the hand joints involved, but smaller joints are given more weightage. Large joints are also involved, but if the smaller joints are involved, then you are more comfortable. And there are more other, that's why it's a it's in the you must know, it's not a joint disease. One day it will call as rheumatic disease, not rheumatoid arthritis, because there are many other systems which are involved, and we see it every day. And so that is the main aim, that you must know that it's a systemic disease, and it can cause many other issues. It's a rapidly progressing course in the early disease. So early disease is a rapidly progressive. So rate of progression is very early. So you should not miss the opportunity at that time. That's why the diagnosis of rheumatoid arthritis is a medical emergency. Why it is medical emergency? Because in first year it progresses very fast, and that is the window of opportunity. If you miss that time, it's like corneal opacity. If the whole cornea become opaque, that is difficult to treat. So it's a medical emergency. That is how it should be. So one is a preclinical rheumatoid arthritis, early rheumatoid arthritis, and established disease. Look, earlier criterias were deformities, this, that, they were based on established disease. Now, at least we can diagnose it early. Now, that time has not come to diagnose at a preclinical stage, and that is what is happening. Like you can diagnose like you don't have a heart attack, but you diagnose a person, oh, he has a triple vessel disease. He says, I'm all right. I don't have any myocardial infarction. I never had a chest pain. But there are various ways to find out this man is going to have heart attack. That is what is happening to rheumatology. That will be diagnosed at a preclinical stage. That is what will happen gradually. And our issue is overdiagnosis also, because you can imagine yourself, if your kith and kin are diagnosed unnecessarily and given treatment unnecessarily. Suppose somebody is not diabetic and you give him treatment for diabetes, that is probably criminal. So probably the issues which leads to the poor diagnosis is poorly qualified doctors, unnecessary testing. We are testing unnecessary, and we always feel probably test will diagnose it. False positive cases, and there are many other conditions which looks like rheumatoid arthritis. Even today, even for me, sometimes it becomes difficult. So let's learn about this. These are the criteria. Let's forget about these criteria because this is for the established disease. Now, this is a new criteria which are also not new, that about 10 years now. Basically, if you really ask me, these are the criteria both by the American College of Rheumatology and European League of Rheumatology. And basically, it is a stress is on the smaller joints. So if the smaller joints are involved, for by and large, for this crowd which is listening, you must know if only larger joints are involved, then probably you are dealing with something else. Maybe. Yes, larger joints also can diagnose rheumatoid arthritis, but smaller joints, that is, more points have been given. And rheumatoid factor positivity, anti-CCP positivity, that is also being given more points. These are the autoantibodies in the, and of course the high ESR and high CRP, that is also given more points. And chronicity. If somebody comes today, Dr. Shah, I have got arthritis for last 10 days, wait. If it is persisting arthritis, probably so chronicity. So a chronic disease, a small joint disease with rheumatoid factor and anti-CCP positivity and acute phase reactant like ESR and CRP. CRP is a protein which is comes from liver, and if there is any inflammation, it goes high. It's not only rheumatoid arthritis, any other inflammation, it goes high. Like in corona, it goes high, CRP. So we talk about CRP. So that is how the one antibodies, which is very well known because of the name. Sometimes name is also very important. The rheumatoid factor. Now probably it should be called as anti-IgG. It's a antibody against IgG. Probably I wish it is called as anti-IgG. So it is the rheumatoid factor, because probably people thought that it is positive in 70 to 80% of the population. So that is the so they start calling it rheumatoid factor, and then we realize no, it is positive in many other conditions, and many other conditions are listed here, that it is positive in many other conditions. So you must scratch your head, is it fitting the clinical diagnosis? Somebody just had one joint involvement and rheumatoid factor positive. Maybe I think probably it is something else. Maybe hepatitis C, hepatitis B, tuberculosis, many other things. It is positive in tuberculosis also, you can imagine. So 15% cases. And normally in healthy population, suppose I get my rheumatoid factor done, it may be positive because 5 to 25% is positive. So if it is in good titer, it is present, and in that clinical setting. So clinical setting is very important. So the anti-CCP antibody is more specific. So it is almost is a very high specificity. So 98%. So this is, and yes, it is positive in many few conditions more, which is, but anti-CCP antibody has a more specificity, and normal is about this is a weak positive, it is a moderate. So basically, if it is positive in this range 40 to 60, then you are more comfortable. So this is the how the anti-CCP antibodies importance is there. Now, this is what our area of research. I'm doing it. I do a lot of synovial biopsies. I do arthroscopic biopsies, and we had established synovial research unit about 20 years back in Rheumata in the Army Hospital. So I used to do a lot of arthroscopy and synovial documentation, and I am very sure you are a surgeon. A lot of orthopedic surgeons are here, and if you can really do a research on synovium, not much work has been done, and I can tell you it's a great area of research, and that is how it is. That is a day will come where rheumatology will be like oncology, where which drug for which patient will be decided probably by the synovial biopsy and the autoantibodies and genes. That has happened in the oncology. If you have a AML, the AML is different. If the biopsy shows different markers, that is what is going to happen. Another is activity. How to measure the activity? So basically, it depends on the 28 joint counts with pain and swelling, AESR and CRP. So basically, whether the disease is active or not. Otherwise, you will have just, in my experience, probably that time has gone. You have to measure the disease activity. And we must know about a few things like cytokines. Now, what is a cytokine? Cyto means cells. Kines is something like you don't say hormone, something coming out of the cells. They are in very small quantity, they work, and they sometimes they can be, as well as rheumatology is concerned, they can be some pro-inflammatory, which induces inflammation, and the leader is tumor necrosis factor, and other cytokines are also there. Just remember that there are pro-inflammatory cytokines, and the God is great, so there is some anti-inflammatory cytokines also. So basically this balance is maintained, and these are called as bad cytokines and they are called as good cytokines. And there are many other mediators for joint destruction. One is, of course, the cytokines like tumor necrosis factor. Some are chemokines and some are MMPs. And so probably there are many other factors which causes joint destruction. So that is the target. The managing rheumatoid arthritis is our topic. And there is inflammation, so use anti-inflammatory drug. You can use the steroid in the initial phase. And since we don't have a cure for rheumatoid arthritis, so you modify the course of the disease like you do for the diabetes. There's no cure for the diabetes. You modify. If you're giving treatment, they're also called disease modifying anti-diabetic drugs actually. So probably somebody has smartly used the name disease modification. So basically, since we don't have a cure, so we modify the disease. That is how it is. And of course, our physiotherapy and other things are there. These are the traditional drugs. When I joined rheumatology almost about 30 years back, the drugs used was gold actually. Then came penicillamine. Both are out, so they are not listed. But as on today, the traditional drugs which I use are methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, and now the biologics are used for many years now, for 20 years. So these are the biologics which I use. And disease modifying drugs, as I said, basically they are slow acting drugs. So biggest problem with the traditional DMARDs are they are slow acting drugs. They takes months for clinical response, and patient has to be informed about the delayed actions. And so otherwise, if you explain them, the compliance improve, that is going to take time. From 1950, as I said, gold was used that time, D-penicillamine used. Corticosteroid is an old drug. D-penicillamine came later on, Azoran, and then came in 60, methotrexate, and other drugs came. Initially, what we were doing, initially people were using, okay, you use NSAIDs for some time, then use sometimes. So gradually we were building, okay, then you use hydroxychloroquine, milder drug for some time. Then we were scared of methotrexate, so use methotrexate little on the higher. So basically, gradually we were building up. Gradually we realized, no, where we are missing the bus. If you don't treat aggressively, then the disease will establish itself, because window of opportunity is just very little. So gradually it is a lot of strategy came. Either you use a single drug, which is called monotherapy, or you use two drugs, there's combination therapy, or you start initially only combination, that if the disease is very active, then you start using 2 3 drugs and then gradually reduce it. And of course monitoring, which we have learned, because all these drugs are potentially toxic. So you must do tests for bone marrow, tests for liver, and tests for the kidney and hepatitis B and hepatitis C. Methotrexate remains the anchor drug. We know about this drug, and this is the man Subbarao, whose name is not there in the textbook, but he was the man who actually made methotrexate. So as an Indian, you must know there's a gentleman called Subbarao who who pioneered the use of methotrexate from 1950 to 9 for the cancer and 1960 for the rheumatoid arthritis. So this that we know about methotrexate very well. Biggest problem with methotrexate is nausea and liver enzymes tolerance. Tolerance is the biggest problem with the methotrexate. It can, even for the dose which we are using it in it, and if somebody is taking correct dose 10 to 15 or 20 milligram, and low dose mucositis is there, and they get nausea, and they get, sometime in a busy OPD you don't bother about that, but they, in a high dose, they can cause oral ulcers, and of course it can cause nodules, and it can cause some lung issues. And hydroxychloroquine, I always feel, is a very safe drug, but the biggest problem, suppose if I give it to my daughter and she will ask me, Papa, what is the side effect? The biggest side effect is the skin pigmentation. So the change of skin tone, darkening of skin tone. So I would not like my daughter to have a darkening of skin tone. So this is the biggest issue. And of course, retinopathy of hydroxychloroquine is rare. It can cause, and leflunomide is a very good drug. Basically, it is as effective as methotrexate, but biggest problem is the pregnancy issue. Even one dose, then the lady cannot conceive for 1 year. So be cautious while using leflunomide. Sulfasalazine is a good drug. And now a lot of vaccination has come. Basically, the pneumovac and influenza vaccine, hepatitis vaccine, before many of this, because it makes it them safer. The we know it that in spite of using disease modifying drugs, they are not foolproof. There are many inadequacies of rheumatoid of disease modifying drug. Sometimes 30-40% time they don't work. They have some side effects, and sometimes their effective is not, they don't induce the remission. So that causes problems. So they are inadequate. So what should be done? So next came is the biologics. And how the biologics came, because when these two cells, when they talk to each other, and they produce a lot of cytokines, which you can remember it like hormone, like we learn about hormone. So they are called cytokines, and these cytokines are many in number, starting from IL-1, IL-2, IL-3, IL-4, all those. So as we discuss about few cytokines, we are inflammatory cytokines, pro-inflammatory. TNF is one, IL-1 is, so basically targeting these, and they have a different name. So they are called as biologics because they are working against these cytokines. So anti-TNF, we know about infliximab and related drugs, and anti-B cell drug, because the cells is you can target either cells. So either you can target these cells, or you can target the cytokines. So this is the anti-B cell therapy. That is the biggest problem with the, so then became the two types of drugs, traditional drugs and biologic drugs. So now, if somebody asks how rheumatoid arthritis is treated, rheumatoid arthritis is treated by traditional disease modifying drugs and biologics. But what was happening with the biologics is the injectable. So first thing is, somebody asked me, I'm diabetic, whether I'll take insulin. I'll say, give me some drug which is oral. Oral is better. I can carry in the pocket. I don't need a fridge. I'm not worried about the cold chain. I am not worried about injection. I'm not. So injection certainly puts you off. So basically all biologics, if you really ask me, they are injectable. That is the biggest issue with the biologics. They are very effective therapy, but they are injectable, and cold chain and fridge issue, that definitely is there. So then came the newer drugs. The newer drugs, one drug is Iguratimod, and another is a JAK inhibitors like tofacitinib and paracetamol. Now these two drugs are making, why they are making this? Because Iguratimod is more safer than JAK inhibitors. JAK inhibitors are like oral biologics. They require more stringent criteria, while this is much safer. So let's discuss about Iguratimod, which is marketed by many companies. The Zydus markets is Zyramod. So this is the Iguratimod. So as I was discussing, the biologics has injectable, and they have some more chance of infection, and very expensive. That is another thing. So biggest is the moment you write these drugs, and if you say somebody that it is the cost is this much, so this becomes so Iguratimod. So In 2008 came the traditional drugs. 2012 came this thing. So this drug came in 2012. So it's not a new drug. In Japan and China, you'll be surprised why it took so much time. The doctors who are relatively new in the field, they must know that whatever Americans makes and Europeans make, they have, you can say, they have more, in the commercial world they have more say. So any drug, you try to make a drug in India and try to market it, nobody is going to buy it. That happens to, you can say, I can give you example, the story of hydroxychloroquine which happened in the corona, that hydroxychloroquine versus versus that injectable drug which they use. You can imagine hydroxychloroquine was equally effective, but gradually Europeans and Americans made sure that hydroxychloroquine is no way seen, and a lot of studies were published. It's not effective. I still feel this happened with this drug also, Iguratimod. It came from Japan, and Europeans and Americans made sure that it doesn't become popular. Otherwise, a very good drug. And 2012, many studies are published from Japan and China. We just attended from those people. We heard from Yamamoto and other people from the horse's mouth. It is an effective drug. And it took about, can you imagine, from 2012, 7 years from Japan to India for approval of DGCI. So you can imagine how it works. And it is approved for active rheumatoid arthritis. Dose is 25 milligram. So you use 25 milligram. Initially, you use a low dose, but just one tablet. And after 4 weeks, you make it 2 tablets, just to be cautious, because it can cause little nausea and transient increase in the liver enzymes. So that is the mechanism of action. It basically, it inhibits. And what it inhibits cytokines, which are pro-inflammatory cytokines. We were discussing about cytokine. So there is a lot of inflammatory cytokines in rheumatoid arthritis. They inhibit those cytokines, including IL-1, IL-6, 8, 17, and TNF, and the TNF and NF-kappa B. Even if you don't remember these names, broadly you remember that inflammatory cytokines are inhibited. That is number one. And of course, the production of immunoglobulins and cytokines. Let me check the time. It is okay. Then, so basically that is one mechanism. Immunoglobulins are decreased. Like if you see, even rheumatoid factors are decreased after use. I was just reading those studies. Then another additional advantage is it is something like anti-inflammatory. Like you use the painkillers because it inhibits COX-2. So that is a very additional advantage. And it also inhibits osteoclast, so bone destruction. But that causes the disability. And it stimulates osteoblasts, so that is an advantage. And it has anabolic effects on the bone metabolism. That is what exactly it has been shown. So that is it inhibits, the blue is inhibition, cytokine. It inhibits immunoglobulin production, and inhibits the osteoclast. And what it stimulates is the osteoblast. And of course, it inhibits cytokine production and IL-7. That is how the rheumatoid arthritis synovium, this is a normal synovium, and this all action is happening here and also in the blood. So this Iguratimod, it inhibits cytokine production. It inhibits IL-17, another cytokine. It inhibits immunoglobulin production. So it inhibits cytokine production. It stimulates the osteoblast, and inhibits osteoclast. So that is how it works. So that is what is written here. So that I'll not bore you with what happens with the osteoclast, with OPG and rank ligand. That we leave it to the rheumatologist and immunologist. That basically it inhibits the rank ligand and OPG pathway. If somebody asks how it works, it action on osteoclast is through the inhibition of rank ligand and OPG. And anti-inflammatory effect is basically by the macrophage migration inhibitory factor. This is MIF. So MIF, it inhibits the activity of MIF, thus inhibits the pro-inflammatory cytokine. Basically, this MIF is needed for pro-inflammatory cytokine. So that is very important. And it inhibits IL-17 mediated inflammation. Just remember this, that there is a cell which is called as T cell. Like we all know about lymphocyte. So there's a lymphocyte and there's a lymphocytes are two types. So one and then the lymphocyte, the T cell and B cell. The T cells are many types. There's one called Th17 cell, and this causes IL-17, and this Iguratimod inhibits IL-17 mediated inflammation. That's all. Don't go this. I think this is for more for the basic immunologist, so you forget about this. Immunomodulatory effects, as I was telling, it inhibits Th17 and it stimulates T regulatory cells. So you must remember that Iguratimod can regulate the immunity by increasing the Treg cell. So Treg cells, just remember, they are helpful. So Treg cells are helpful. They are Th17 cell bad cells. So they downregulate Th17 cells. So when they downregulate these cells, these are the cytokines which are inhibited. So that is how it is. And for B cell, what they do, they can suppress the B cell terminal differentiation by, just don't read this thing, by production of immunoglobulins. So inhibit the production of immunoglobulins, but they do not inhibit the proliferation of B cells. So B cell number does not change. So that is very important. So if you really remember, this is a T cell and this is a B cell. What they do, B cell, the production of antibodies are less, but the production, but they don't interfere with the proliferation of B cells. So infection rate is less, unlike other like if you really ask, there are a lot of drugs which depletes the B cells. So it's not then by. So basically, what is the where it is used? It can be used as a combination of, you're using one drug, you use this drug. It can be used in moderate rheumatoid arthritis. Rheumatoid arthritis not responding to other drugs. The basic protocol, even today, how it is, if you really see the protocols of the rheumatoid arthritis written by APLAR, that is the Asia Pacific League of Rheumatology. We are member, India's member of that. That if rheumatoid arthritis actually should be treated by one drug. That is, so initially you start just with one drug. So the drug of choice is still methotrexate. For some reason, if methotrexate do not respond, because about almost 30 to 40% people don't respond to methotrexate, and because of side effects, then you can use the combination. So when they don't interest, so you can use you can use as a combination of this drug. And of course, an additional advantage is it has a COX-2 inhibitory effect. So it's like NSAID effects of the, and maybe one day it can be used as a first line of rheumatoid arthritis. We really don't know. But since the standard of care is methotrexate, the most effective drug is still methotrexate. So all drugs are tested against methotrexate. But one day you never know how it will be used. That as on today, we are using in the combination. So basically, it is a short half-life. So elimination in 10 hours, that is one advantage. And the food does not affect, so it can be taken. Normally, we are always advised after food. And because of the acidity issue, the upper GI issue, so like even methotrexate, we always say take after food. The bioavailability is not affected by food, and excretion occurs in the urine. So that is the special precaution. We don't have a data on pregnancy. We don't have a data on lactation. So especially rheumatoid arthritis, a disease of women, especially those people who has a busy practice, first thing they must discuss, are you planning for a baby? You're a newly married girl. If that is there, so then it cannot be used for pregnancy. It cannot be used for lactation. We don't have a data for children use. And of course, for geriatric population, more monitoring is required. Some side effects are there. Basically, there are many, every disease, when every drug which is, when it is research, small points are noted. But if you really ask me, the real world data says the biggest issue with this drug is basically a loss of appetite, like methotrexate. So that issue is there. And transitional increase. So the word is transitional. Unlike methotrexate and leflunomide, the liver enzymes goes up for some time, and then for some reason they come down. So that is of course, other small side effects are there. But what is most day-to-day practice, you must remember the loss of appetite and the transient increase in the liver function. So I said nausea and hepatic dysfunction. You must remember these two things. Safety is generally safe, well tolerated in comparison to other DMARDs. I always put it somewhere, something like hydroxychloroquine is a very well tolerated. Some GI effects are seen in the long term, and transient increase in liver enzymes and liver functions should be done periodically. And many clinically studies has been done, and it is full, the whole literature, whether it is if you really ask me, this is one study published as a review article. Basically, the conclusion of this article is efficacy and tolerability are comparable to sulfasalazine. As we were discussing, it is as good as methotrexate and sulfasalazine, and adverse effects were less with the Iguratimod. This is another study which is published in Clinical Rheumatology, and it's a 6-month study of the efficacy and safety evaluation of combination of Iguratimod with methotrexate. So basically, after 24 weeks, methotrexate plus Iguratimod shows statistically significant this thing. So basically, it is it is an effective drug. And then about the sulfasalazine, the conclusion is efficacy is better than sulfasalazine. I don't want to bore you with these charts and all. These charts are done and very methodically, but just read this. This is better than sulfasalazine. So that is how let me switch off this. Then versus leflunomide, this suggests that Iguratimod has better than leflunomide and has a sustained therapeutic effect. So it's a long-term study. So it's not only short-term study, it's a long-term study. And this was a study, 52 weeks long-term safety, and is effective in refractory rheumatoid arthritis. Basically, it's a very interesting study. The patient was also already on methotrexate, cyclosporin, hydroxychloroquine, prednisolone. So 3-4 drugs, and it was they added Iguratimod to it, and they concluded showed a synergistic effect in combination. So probably yes, it is another drug for the. Then it's a monotherapy. Now what we are discussing, this is a monotherapy which is original article that had a similar efficacy and similar safety profile compared with methotrexate. The patient on Iguratimod had lower CRP and ESR level, swollen tender joint counts, to enhance Iguratimod as a potential alternative to methotrexate for the treatment of active rheumatoid arthritis. So basically, long-term safety, short-term safety in combination this is a effective in rheumatoid arthritis for the. So many studies are there. Even you can combine with the etanercept. This is a study where it can be combined with like we combine methotrexate with the biologics. So this is a study which was published in Biomedical Research, that it can be combined with the biologics also. So many different trials are here. So other indications have also emerged because of the multiple actions. It can be used in lupus nephritis, Sjogren syndrome, ankylosing spondylitis, IgG4 related diseases. So many other immunological disorders it can be used. My only worry is it should not be misused without realizing that it can cause, because it is acting on multiple cytokines. After it is blocking IL-6, IL-1, TNF, IL-17. So basically, it can lead to a lot of other issues if you misuse it, because it can be more and more data is emerging that it should be like any other disease modification. You must remember that they can make you prone for infection. That is number one, because these pro-inflammatory cytokines are needed to fight the bacteria. So if you're blocking that, that's why if you use anti-TNF, you have more tuberculosis. So your infection remains the most important thing. So basically, if you are little less attentive, you will miss infection. You miss a little fungus infection in the lung. You will fungus infection there, maybe a tuberculosis, maybe a gland there. So you must remember about infection. And another area which is emerging, that it can be used for pulmonary fibrosis also. And this is the I took from the this I took from the net actually, that anti-fibrotic effect is of the. This is a very interesting thing, that the Iguratimod, which is not there neither with methotrexate, nor with leflunomide, not with hydroxychloroquine, that it has an anti-fibrotic effect. And a lot of experiments were done in that yes, it has an anti-fibrotic effect. So maybe it will be used for interstitial lung disease or maybe systemic sclerosis. We really don't know. So it's a novel molecule. It is a relatively new molecule. It is only approved by a drug controller of India. It has excellent dose compliance and effective either alone or in combination. And why? Because of the immunomodulatory effect, anti-inflammatory effect, and antioxidant activity. So it's probably the next generation DMARDs. It is a better established safety in comparison to others. It can be probably used as a monotherapy also, and long-term data is also available, and multiple new indications are emerging. So to conclude, Iguratimod is one more disease-modifying anti-rheumatic drug. It has properties of immune modulator. It is a property of decrease antibody production. It is anti-inflammatory also. It is effective, safe, but those who are using it, they must remember that it can cause GI side effects, especially nausea, liver enzymes, and few studies have shown which are it has an interaction with warfarin. So if some patients are on warfarin, it can cause lung hemorrhage. So there was one case of lung hemorrhage. So you must remember that it can cause. And liver enzyme rise is usually transient, and more we use, more we know. So that is what I wanted to present about this new drug, Iguratimod, which has come from Japan, and a lot of studies already available for China and Japan. So let's use it more. And it is somewhere, I will place it somewhere between methotrexate and hydroxychloroquine. It is as effective as methotrexate, is as effective as sulfasalazine. It is as effective as leflunomide. It is definitely safer than cytokines, than biologics. It has, if you really ask me, one advantage over methotrexate, is the liver enzymes rise is actually transient. Nausea is also very transient only. So that advantage is there. So it's a one more addition. More and more we use it. Frankly speaking, if you really ask me how many cases I have used it, I must have used hardly about 20-25 patients. That's all. So basically, we are also learning about the Iguratimod, though this drug is available from 2012. For some reason, probably because of maybe other factors than efficacy, maybe people have not marketed it well. If you market it well, it is we have another weapon in our armamentarium. So thank you, ladies and gentlemen. Thanks a lot.
Yeah, thank you, sir. Thank you for an excellent presentation. We'll take up a few questions which have come in. We'll start with the most commonest ones which are there right now. As you said, sir, this is a drug which we usually add on to the conventional DMARDs. Like, for example, sir, like one question which has just come, it's asking us when we are starting with conventional DMARDs, okay, we know the patient is an RA positive patient, we have to be a little aggressive. We start with the conventional DMARDs. Then what is the time when you would like to add Iguratimod to this, and which drug would you like to stop after adding Iguratimod?
Yeah, very important. Actually, if you really ask me, the Indian practice for some reason is to use multiple drugs, maybe for whatever region. But if you really ask me, the guidelines say just treat with one drug, that is methotrexate. So the first drug should be used as methotrexate. But most of the Indians are using hydroxychloroquine methotrexate for many reasons. So if you're using methotrexate, and if you're monitoring it with the DAS28 and other, and if it is performing well, in 3 months time, you know whether you are using biologics or you are methotrexate, that the drug is effective. In 6 month time, we should have a very less of the disease activity, which we call it either a complete remission or a low disease activity. So basically, if your DAS score is less than 2.6, then you say methotrexate is working. If it is not working, that is what it is called treat to target. Means either you become haphazard. You keep adding one drug, another drug. One day you come, okay, you take this. But if you are a methodical doctor, you know it in 3 months time, generally your disease activity become half. In 6 months time, our target is to reach the low disease activity or in complete remission. Complete remission is very, very difficult to achieve. So what we do, suppose the patient is not doing well, you start a methotrexate and patient is not doing well in 3 months time. In 3 months time, you know that drug is not working well, probably the disease activity. At least in 6 months time, you are very sure that it's not, then you can add this. Otherwise, in 3 months time, we generally have a change of course of action in 3 months time.
Right. So minimum we need to wait for 3 months, sir. That is
Yes.
what you need to implement. Right, sir. Excellent. So then another question, which is a very interesting one. This has come from one of our doctors from Gujarat side. He wants to know, like we have conventional DMARDs, we have biologics, now we have the novel DMARD as well as we have small molecule. So what is your preference of order of starting these drugs? How would you
Look,
position these drugs?
it's not my personal science is a done by people. It is a scientific structure. Like even today, diabetes is treated by standard drug, which we know that diabetes is treated by the same drug which my father used to use it. So in spite of multiple drugs of diabetes, it is what is that drug? The common drug is not coming in my mind. So
Metformin.
not metformin. That is the it will come. So basically, the standard drug. If you see any, whether you see the ACR, you see the EULAR or see the APLAR, these are the bodies. These are the scientific bodies. They decide. In America, American College of Rheumatology. In Europe, European College of Rheumatology. In Asia, in the Asia Pacific APLAR. And the scientific committee, they sit down and make guidelines. And guidelines, how they make, it is based on publications. You publish today that Iguratimod is effective as a monotherapy. You conduct a trial, but it should be honestly conducted trial. Unfortunately, most of the trial conducted in Asia, at least European things, they are not very good trial. That's why they don't bother for us. Probably they say you are writing for publication's sake. You are not writing for the sake of science. You use it and you say it is useless. So I'll be very happy if somebody say, oh, look, I use Iguratimod, it is useless. Or you say, no, I have used it, it is as effective as methotrexate. Somebody has to do a very honest study and very meticulously done. Actually, meticulous studies requires a lot of money because everybody is blinded. I also don't know which drug I am using. That's why it is called double blind. So that probably all these studies can be done by those people who are used to it. It requires a lot of money. That's why all the studies come from Europe and America. So you conduct those study. My experience does not matter. The science says it should be one drug should be used to treat rheumatoid arthritis. If a new case of rheumatoid is there, if you see the guidelines, it is written as monotherapy, preferably methotrexate. If methotrexate is contraindicated for some reason, then you can use leflunomide, sulfasalazine, and Iguratimod also it has been included in the APLAR guidelines. In fact, I wanted to include that slide, but time was running out. So I had already downloaded that slide, that methotrexate is the first drug. And for some reason you can't use methotrexate, then all can be used, including Iguratimod.
Right. Excellent. Yeah. Coming to the next question, sir. This question wants to know about the duration of the therapy. Once you start Iguratimod, how long should you give it?
Yeah, in fact, when I appeared for the exam for DM, the question was asked. That time it was methotrexate was also a new drug. So how long you will give methotrexate? Somebody asked me. The examiner was from South and a very traditional one. So I said lifelong. So he says, are you all right? I said, yes, it should be lifelong, because the disease is such. It's like treating diabetes. So if patient asks me today how long I should use, I should be very, yes, the same thing should be conveyed, which we all are good physicians, should be conveyed in a better way. Look, probably it's for a long time, but if you really ask me heart and heart, gradually patient also understand that it should be taken for a long time. Yes, once the disease goes in remission or disease go in low disease activity, then you can reduce the dose. So reduction of dose is, we all do it. We all know that.
Right. Right. Excellent, sir. So what are your parameters to monitor when you're starting a drug like Iguratimod, or for instance, any conventional DMARD? Is it the DAS score which you always look into?
Look,
Or some related
my
ethical?
first thing is today, because of the, look, you may not go to jail by writing Chwanpras and having a renal failure, but certainly today patients are reading much more than me and you.
Absolutely.
The slide which I showed about side effects, after all, we always see it is only nausea and liver, but if you see, there are 2,000 more side effects. And the judge which is sitting there, he will say, why you have not told the patient? So my own view is, yesterday we were discussing about the drug, the small molecules. We realized that it's better to take consent, even for, in this country especially, which is the new legal proactivism is coming. I can tell you one single case and you will always be blamed, because the science is such. The first thing, and only on two accounts you can be blamed. You are not blamed for your competency. You will be only blamed for two things. Have you taken the consent?
Absolutely.
That's all. So my son is an advocate. He only understands that his judge will only ask, have you taken the consent? No, consent for me and you looks very simple. For them, consent is like something like, you can say, consent for romance. It is something like, have you consented?
Absolutely.
Otherwise, a rape. So if you're raping a patient, if you're not taking the consent, so take the consent. Best is make a booklet and take the consent that I have been explained about the side effect and effects of disease modification. Now, it can cause infection. We know it. Methotrexate can cause infection. Leflunomide can cause infection. Biologics cause more infection. So infection range is there. If somebody wants to trouble you, he will trouble. So what I do, first thing, I do monitoring of the kidney function, liver function, bone marrow function. Generally, we try to vaccinate if we have a time with the flu and these, and do all those which is done for the biologics. Like you do a good X-ray chest, you must do the KFT, LFT, you must do hepatitis B, hepatitis C, HIV, and Mantoux test. Because actually speaking, they should be done even for methotrexate. We are not doing it. But if you really have established practitioner, if everybody knows you, like Dr. Salim, so if I'm a patient, if I want to trouble you, I'll trouble you. You have not. So more and more you establish, more and more you should be careful. So just a one single signature is needed. His patient have been explained about, and get in writing in Hindi or Gujarati, wherever you write, I have been explained about this. So whole thing is typed also, and the same time write also. So consent become number one. Now, how you monitor the disease activity? You monitor the disease activity by seeing the swollen joint count, tender joint count, ESR, CRP, and patient global and your. So basically, the score is there, which is available on the net. So you calculate DAS28 and you document that disease is becoming better or disease is not becoming better.
Right. Excellent, sir. Excellent. So another question regarding the analgesic or the anti-inflammatory effect of Iguratimod. Do we really need to add an NSAID once you are giving Iguratimod? Like for example, suppose you need to add like
Yeah, that's a very interesting question you've asked. I also thought same way. Probably maybe we could, somebody has to write a paper, separate paper, or I have to see the literature. We can write that yes, this is another advantage. If it is if it is inhibitory to the COX-2, probably we may not. So that is an additional advantage. So probably yes, the question is pertinent, but answer has to come from a good study, a controlled study.
absolutely excellent, sir. And what about replacing any other conventional DMARD when you start Iguratimod? So which drug would you prefer to stop and then start Iguratimod?
No, it is just one more drug. So
Okay.
you are using
Then
methotrexate. If it is not effective, then you use Iguratimod.
right.
Probably, if you ask me, by and large, they have the same efficacy,
Right.
and by and large, is the same toxicity profile.
Right, right.
Leflunomide has more problem with the liver. Methotrexate has more problem with the liver. So if suppose a patient of cirrhosis comes, so I'll not use leflunomide. I'll not use methotrexate. I'll use a drug which is more safety profile. So the more safety profile is hydroxychloroquine has more safety profile. Iguratimod is just a transient. Most of the studies has shown that there's only transient increase in liver functions, and you use it, that liver functions comes normal as SGPT. It doesn't happen with methotrexate and the leflunomide. If the liver enzymes are high, it will remain high and keep increasing until you stop the drug.
Right, right. Excellent, sir. So one last question. Now, this is regarding like one of the slides which you had shown that JAK inhibitors are like your oral biologics. So, sir, would you prefer to start a drug like a novel DMARD like Iguratimod before giving in to a JAK inhibitor? What would be your line of thinking?
Look, yesterday we had a meeting and there was a lot of discussion that really the JAK inhibitors, which is now marketed by many companies, and it should be used very, very cautiously. It should be, in fact, used very cautiously more than biologics. Look, when we write biologics, even as a rheumatologist experience, I always feel one single tuberculosis, one single hepatic abscess, one single death may affect my practice. So I always first I have to save my skin. So you must remember, when you're writing the JAK inhibitors, you should be more cautious because they are oral drugs. You don't have a control. With injectable, you still have a control. Patient will certainly come in 3-4 months time to you, look, I'm using this. So the moment you lose the control on oral drugs, and there are innumerable same infection profile, whether it's a tuberculosis or a fungal infection or a perforation of the bowel, the oral JAK inhibitors, because they block multiple cytokines, and their cytokine efficacy is much more than Iguratimod and others. So Iguratimod, they also inhibit pro-inflammatory cytokine, but the efficacy of JAK inhibitors is very profound, like the biologics. So they have more side effects. So you should be very cautious about that. So you must use the traditional drug first. If they are not effective, that is what the even the guideline says, that you use these drugs which are more safer oral drugs, but the small molecule JAK inhibitors has similar side effects as the cytokines, as the biologics. You should be very, very cautious.
Absolutely. Excellent, sir. Excellent. And so this is the final question, sir, because it's come from one of our orthopedic fraternity. They are very much interested in using a oral DMARD like this. Now, their question is, suppose a case of rheumatoid arthritis with a severe deformity, we need to take them off for a joint replacement. So should we stop these drugs a few days before the joint replacement, and after the joint replacement, when do we start them?
Look, everything has a cause in science. Why we want to stop it? Because we are worried about infection.
Right.
We are worried about poor healing. Look, joint replacement is not done every day. It is a one time. So if I'm an orthopedic surgeon, though books always say nowadays a lot of papers are coming, you keep continuing methotrexate. Don't worry about that. But if I'm an orthopedic surgeon, or as per the safer guidelines which was there, that you stop these drugs, say about maybe 15-20 days and maybe 1 month early, and then you can start later after a month when the healing occurs. So basically more safer, especially in country which is full of infection, our own hospitals, our OT, our everything, probably our processes are not very foolproof. So best is, but otherwise if you read the more of the guidelines, people say if you're using methotrexate, you continue methotrexate. If you're using biologics, you can stop say maybe a month early, and then, so basically, so that the immune system, the healing of the your of the joint that goes. So if I'm a surgeon, I'll be playing very safe. So that is how it is. So I'll stop it 1 month before the surgery, or maybe at least 15-20 days.
Right. Excellent. Excellent, sir. Thanks a lot. Thank you, sir, for answering all these questions so fluently. And I would request Dr. Neeraj for a closing statement. Yeah, Dr. Neeraj, are you there? Thank you, sir. Yeah, Dr. Neeraj. Hello, Dr. Neeraj, are you there? Okay, I think he must have a network issue probably. Right. So, sir, on behalf of Ortho TV and Rheuma TV and Zydus Synovia, we thank Dr. Ved Chaturvedi, sir, for giving us this time on a busy Sunday afternoon as well. So, an excellent talk, a good discussion about a novel DMARD like Iguratimod. And on behalf of Zydus Synovia, I thank sir for his valuable time. And a message to all our delegates is, being a Sunday, thank you for joining us, and stay safe, stay protected, and have a happy Sunday. Thank you, sir.
Thanks, Salim. Thank you very much for conducting it well in time. Thanks a lot.
Thank you, sir. Have a great day, sir. Bye, sir.